Chairman, for the opportunity to present here. Honestly, this is the most beautiful place I've ever been at a medical meeting, so I'm very much enjoying being in Italy and enjoy the hospitality and delicious food. So I'm going to change gears a little bit and speak about my experience and something I've been passionate about for the past 15 years, using radiation as a tool to treat hepatocellular carcinoma. And the underlying hypothesis behind using radiation is really that as a local therapy, that is actually well recognized for most cancers. Radiation is understudied in HCC. And about 15 years ago in Michigan, with my prior boss, Ted Lawrence, we had the hypothesis that radiation can help patients with both primary and metastatic liver cancer. And that's from very end-stage disease, patients with symptoms where we can palliate, to the potential other end of the spectrum for early stage where radiation could be an alternative modality to be used. And just like everyone else, radiation doesn't have a spot in the BCLC classification, and for local therapies and regional therapies, we do recognize the challenges in advanced HC, not separating out those with metastases. What I have on the bottom is a modification to the system that I propose as a radiation oncologist of where there's an opportunity where radiation can help patients. And as I mentioned from the very beginning, if someone for whatever reason isn't eligible for transplant, resection, ablation, or regional therapy, I do not see these patients, but there's excellent outcomes in some early stage disease in Japan and other countries. We do use radiation in our center and others as a bridge to transplant when there's other local regional therapies aren't possible. But where I think potentially the largest role for radiation is when there's no other competing local regional therapies. So portal vein thrombus, advanced C stage, and there's opportunity to study the benefits in a randomized trial. And finally, very low dose radiation can actually help patients feel better. So palliation. Even low dose radiation is underutilized in hepatocellular carcinoma. And as I had a liver radiotherapy program not designed for palliation, I ended up seeing some patients who were sick from the great burden of diffuse liver disease. And thus, I actually ran a palliative study looking at patient-reported outcomes. So this is small. This is just being sent for peer review now. We also tested this in metastases, and overall this is single fraction radiation even used in patients with child cirrhosis if they have pain or discomfort from the great burden of disease. Easy to do, don't need technologies. You need to make sure you give antiemetics prior to radiation. And from a patient perspective, 50% had a substantial clinically relevant decline in their pain, and 40% had improvement in their quality of life at 1 month after therapy. And based on this, we're interested in starting a randomized trial at end-stage HCC, best supportive care versus radiation and best supportive care, to be run through Canada and CIC. So the other end of the spectrum, where we potentially can help patients in terms of their disease-free survival, is more challenging. And there are many different means to deliver ablative dose radiation to liver cancers. We just heard about yttrium. And I'm going to focus today on the external beam techniques. But even with external beam techniques, there's a huge spectrum of different variety of techniques that can be used to help patients. So I'm going to first a little bit review some of the technical advances that made radiation possible to treat liver cancers, and then some clinical outcomes. So the reason perhaps that radiation is slower to be used in this cancer compared to other cancers is because of the potential for toxicity. And radiation-induced liver disease toxicity was first described in patients with non-HCC, but can be fatal and is similar to a veno-occlusive disease type of toxicity. And this really, I think, scared everyone, oncologists, radiation oncologists, and really led to a delay of radiation, and a delay for good reason. We didn't have the technological advantages to focus radiation until the past few decades. And other toxicities can be seen. And clearly, avoidance of these has to be a priority as we introduce new techniques into the clinic. There are now good dosimetric guidelines to help reduce some of these forms of toxicity. This is an example of one study from Taiwan. saying if we can spare 800 Cs, less than 18 gray and 3 fractions, the risk of decline in child score is very low. But conversely, some patients don't have 800 cc's of liver, they have multifocal disease. So this also is a little bit selecting the worst patients with less reserve, but they also are at risk of toxicity. And we and others have published other guidelines. These are much better understood in child PUA patients than child PUB. Before we go ahead with radiotherapy, there's some considerations. One, clearly, we always use a multidisciplinary clinic, and at present, radiation is one of the lower treatment options, considered only when other standard treatments aren't available. And even in the palliative center, if the patient can be decompressed for biliary obstruction, if they had biliary duct cancer, that's the treatment of choice. And that may be done before to decompress a patient, even if there's a potential for ablative radiation. And clearly being assessed by hepatology and treating of hepatitis B or banding of varices is necessary. And at present, we don't combine our therapy with any systemic or regional therapies unless on a clinical trial. And something where we do, and many centers work with interventional radiologists, is insertion of fiducial markers that can help in the precision of radiation. There's one strategy where this is important. And something that has not really been exploited, but I think is very important, is tissue expanders. So moving the stomach or bowel away from a hepatocellular carcinoma can really help increase the therapeutic ratio for radiation. So for external beam radiation, as I mentioned, we can only do it because of advances in imaging, bringing in diagnostic quality imaging into our radiation systems, accounting for deformation, dealing with breathing motion, and advances in planning and delivery. And image-guided radiation really has revolutionized our ability to treat the cancers more precisely with less room of normal tissue irradiated. Stereotactic body radiotherapy, or SBRT, is very popular in North America, some places in Europe now. And what this really refers to is highly conformal radiation delivered to a tumor with many beams and rapid fall-off in dose from 100% to 50%, for example, within a centimeter. And also all the technological tools to deliver radiation precisely are needed. In the US, it's defined as 5 or fewer treatments. So that's actually read by a billing code. So there may be other radiobiological reasons to use these techniques, but give longer fractionations. But these techniques are relatively widely available in North America, in some places in Asia. I'm not so sure in Europe. I think there's a little bit more variability in whether these tools are available. This is an example of a radiation plan. This is actually very small. Cancer near the esophagus with a high conformality. And this is more typical plan. So a patient who has a portal vein thrombus, and this is indicating the volume to be treated, and the pink is actually the prescription dose for 35 gray and 5 fractions, with fall-off, as you can see with the yellow line here. And this is relatively typical of the kind of patient that we treat in our clinic. One of the technological advances is high dose rate radiation, where we can remove a flattening filter from the linear accelerator. And what this allows is the treatment to be delivered very fast. So one treatment for this patient is 110 seconds, for example, with high conformality. Many different ways to deal with breathing motion. In our clinic, we have tools to measure how much the liver moves with breathing, and about 60% of patients we treat with breath holds. So repeat breath holds of 15 seconds. The other 40%, some have compression on their belly, and some don't have any intervention for the breathing motion, and we individualize patient treatment based on what their treatment is. But regardless of how we deal with breathing motion, the liver, as many of you may know, shifts relative to the vertebral bodies day to day and can shift substantially. And that's why we need to image immediately before delivering the radiation every fraction if we want to reduce the volume of normal liver irradiated. This is referred to as image-guided radiotherapy, or IGRT. And there are many tools involved. And this is probably 10 years old, so there's now, in fact, many more tools that are now available to help with image guidance. One of the first descriptions of IGRT in liver cancer was with ultrasound by Martin Fuss in San Antonio. Now most image guidance is KB cone beam based or MV CT based. And up and coming, there's now several different systems becoming available where MR guidance can be used in the clinic with also combined technologies. A common, relatively easy way to guide patients is by inserting fiducial markers and doing orthogonal x-rays. Clearly you don't have the advantage of seeing the liver or soft tissue, but this is a system that works that is dependent on inserted fiducial markers. And this is, as I mentioned, what we do in our clinic with a single rotation from a minute. We obtain KB projections and then a reconstruction of the liver simultaneously. And this is now commercially available on many, by at least 3 vendors available in most clinics. So within a minute, we can get a reconstruction of the tumor, of the liver rather. We don't use contrast routinely at the time of treatment. And these are the kind of images you can get. This is actually 2005. One of the first patients, we did home beam CT before it was commercially available. This is a patient, this patient had here imaging during free breathing, you can see blurry, but if we only extract those projections taken during the exhale phase of breathing, we get a better representation of the liver during exhale. And finally, you can see the advantage of breath hold, of course, reduces those artifacts, and now we're starting to be able to use this type of tool for image guidance. So what about if we can't do breath hold? Well, respiratory correlated home beam CT will allow us to see the motion of the liver even at the time of the treatment unit. And if that we can see this motion, we can ensure it's not more than we anticipated and help to do guidance. And very useful for us is if a patient has had prior taste with Lepidol. It is a good surrogate and it can help automated positioning of the patient and matching. So very much I like if the patient's previously in the past year have had taste. So how have these technological advances helped patients? Well, just to review, in fact, amazingly enough, so radiation's been used to treat cancer for more than a century now. And there's reports of it being used in 1924, but clearly it didn't take off at that point. And the reason is that as radiation was becoming appreciated as a tool to cure Hodgkin's disease and seminomas and pediatric cancers, unfortunately at the same time it became clear that radiation toxicity can lead to deaths. And this really put radiation off the radar for quite a long time. And it wasn't until 1986 when the potential for giving focused radiation to part of the liver was described. University of Michigan in North America developed protocols using conformal radiotherapy. In Europe and Sweden, Blomgren described using stereotactic radiation, relatively simple techniques in 2005. And since then, in fact, many more now finally prospective studies. And with SBRT, as I said, this is very popular in the US and North America anyway, many prospective studies. First of them using single fraction, 3 fraction, now some myself, 6 fraction, and ongoing. I'm sure there's many more in the past month that I haven't yet referenced. So what are the outcomes in general? This is the non-SBRT, some published papers. Majority of these papers are retrospective, other than Michigan and France. And majority of these series are small, with the exception of the Asian experiences. And this by no means is comprehensive, but just to show there are some centers with extensive experience and some centers with relatively impressive outcomes, albeit the selection criteria for different series varies quite considerably. So proof of principle that some cancers can be treated radically with radiation. And from Japan, using protons, a very elegant type of way to give radiation with far less dose to the remaining liver, some of the best outcomes have been published. And so this is a retrospective series published in 2005, and 2 things. One, it showed 90% local control at 5 years, 50% survival at 5 years in selected patients. But also important, it presented that you won't see your late toxicities until you have many long-term survivors. So this paper describes biliary toxicity, and it's the only paper in radiation literature that describes this. So I think we need to be aware of it in our field to treat central lesions involving biliary system much differently, or be cautious rather than just treating them similarly. And this group, kudos to them for replicating the work in a prospective environment. In fact, not including those central lesions in a prospective phase 2 study had very similar outcomes. 5-year local control 88%, 5-year survival 39%. Clearly these were early lesions, no portal vein thrombus, but proof of principle radiation can help, and also we need to follow patients for a very long time if we're going to see unusual toxicities. In Michigan, the approach was a little bit different. This is again non-portal vein thrombus patients, but medium-sized 10 centimeters, so large tumors. This is pre-sorafenib era, and in fact, even now many of these patients would be considered for taste, but at this time that wasn't available in Michigan. The radiation is twice daily, and using a hepatic arterial FUDR as a sensitizer, so a complicated protocol. Patients were in hospital for some of the days during the therapy. And this was a phase 1 study originally designed to learn what the tolerance of the liver is. And of these results, 82 patients with HCC child A were evaluated, and their median survival was 15 months. And response rates, not impressive, but stability of disease in many patients. So first prospective study that was published saying there's radiation, even modest dose for large tumors, may benefit patients. And also similarly, metastases, there appear to be some benefit. Also, from this experience, we could learn about toxicity and how to avoid toxicity. The study was designed to look at liver toxicity, but clearly with 5% of patients having GI bleeding, we learned a lot about the tolerance of those organs to toxicity as well. There's one multi-center prospective study in Europe, and this is from the French group, François Mornay. And of these patients, it was relatively simple conformal radiation, 66 grain, 2 Griffith fraction, 60% 2-year relapse-free survival. Child B patients were included as child A. These were small tumors, so excellent control of disease, little toxicity, but higher in child B, not unexpected. And I'm sorry for the small font, but this is, to my knowledge, a summary of all of the published SBRT experiences for HCC. And most of them are from the past few years, and still the number of HCCs treated in these published prospective studies is small. A variety of fractionations, a variety of follow-up, still some very short follow-up. And in addition to the ability to treat cancers, I think a cautionary note is that treating HCC is not without risk. And so many of these patients had some transient decline in their liver function, some not transient, and some GI luminal toxicity was also seen. And both toxicities were more common in child Q VOC patients, again, not surprising. So what about the portal vein thrombus patients? They're challenging for all of us, a poor prognostic factor. There have been many series published, many different fractionations, standard fractionation, now more recently SBRT. Some have combined radiation with TACE. And in approximately 50% of patients, there can be some evidence of recanalization of the thrombus, but it varies in the series. And the median time to actual response is 6 months, 9 months in my experience, so it takes a long time for the recanalization to happen. And a variety of median survival results from these group of papers. I'm just going to highlight 2 papers in addition to our experience. This is from Yonsei in Korea, looking at 40 patients with portal vein thrombus where relatively modest dose radiation was used, 45 and 25 fractions, using hepatic arterial 5-FU as a sensitizer. And following that, giving chemotherapy. So clearly there's some selection for fit patients despite having portal vein thrombus, and median survival 13 months. A recent study from a different group in Korea has looked at a very large group of patients, over 400 patients with main or main branch portal vein thrombus, malignant, main or bilateral 50%. There were 45 child B patients, majority child A, and all of the patients had some type of TACE, either relatively recently prior or following therapy once the portal vein recanalized. Response is shown here, median survival 10.6 months. And from a toxicity point of view, similar to even the non-portal vein thrombus patients. So what about our experience? I'm from Canada, but I worked in Michigan for 5 years, and about 10 years ago I moved back to Canada. And at that point designed a 6-fraction SBRT study that is much more logistically acceptable to patients in the healthcare system than twice-daily radiation and hepatic arterial chemo. The phase 1 study was to determine if this is safe, if we can treat lesions both big and small with radiation using hypofractionation. We did have secondary endpoints of efficacy and quality of life as well. And the first experience was in 31 patients, and some of the descriptors are here. About 50-50 Hep B, Hep C in this initial experience. All were not suitable for any local regional therapy. This is prior to sorafenib era, and the prior treatments for patients are shown here, and reasons patients wouldn't have been offered TACE or RFA is that they weren't eligible at the time they came in or had medical contraindications. I don't think I had an age. I've treated a 95-year-old patient in this original experience who wouldn't have been suitable for other therapies. Just over 50% had portal vein or IVC, malignant thrombus, and the tumor volume, in some cases, very, very large. So in our first feasibility study, we did show 12-month local control, meaning no progressive disease of 74%. And the most common site of recurrence was in the liver outside of the radiation. Again, not surprising given that these patients had advanced stage HCC. Portal vein thrombus, of course, an adverse factor, 11.6 months median survival for those with thrombus, 17 months in the original experience for those without. We did see some toxicity. In general, the treatment is very well tolerated, easier than pancreatic radiation or other upper abdominal radiation. We didn't see any of the classic radiation-induced liver toxicity because we used prior studies to design our dosimetry and individualize the dose so this can be avoided. We saw some patients with elevated liver enzymes, but many patients in fact had elevated liver enzymes up front. One nausea and vomiting. Most important is that there were a handful of patients who had a decline in their Child-Pugh score. And these patients shown here, 3 had rapid extensive progression of their cancer despite our intervention. So that may have contributed. 2 were borderline A6 patients who were B a month before, and the other one was very large. So plotting these patients compared to the whole group, this is the dose of radiation used in 6 fractions, and this is the effective liver volume irradiated. And the yellow shows those who had a decline in their child score from A to B at 3 months' time. And so based on our phase 1 experience, we then decided we need sensitizers and tumor and liver protectors for this higher risk population, and we went on to do phase 1 studies that are ongoing and still haven't been published. But for our phase 2 studies of radiation alone, we limited the effective volume of liver radiated to 60%, not 80%, and otherwise kept our planning criteria very similar to what we learned in our phase 1 studies. And so our phase 2 experience now, we have 102 hepatocellular carcinoma patients. This is the child A experience. We haven't yet analyzed our child B patients. And again, similar breakdown to the phase 1. Prior therapy is 50%, portal vein thrombus 55%, extrahepatic disease, albeit small, volume in 12%, and median size 10 centimeters, one very small, but the great majority are large. Modest doses, so 36 grains, 6 fractions. And in fact, hepatocellular carcinoma is very radiation sensitive, even at modest doses. So local control, 1 year 81%, 2 year 54%. By no means is this enough, but in our phase 1-2 experience with large tumors, some patients we can have sustainable control. And the most important factor on multivariate analysis for local control is the radiation dose. And that's somewhat related to the burden of disease because we're often limited to give a smaller dose to larger tumors. Overall survival, median survival 17 months, and the prognostic factors for this included portal vein thrombus, as well as the treatment era. So this is looking at survival by trial. So the first 52 patients, our median survival is 11 months. The next 52 patients is 25.5 months. And both of these groups had about 50% portal vein thrombus. So maybe our more recent selection criteria helps, but I think there's also a learning curve in radiation oncology that with more experience, more multidisciplinary collaboration, perhaps we're choosing patients better than we realize, even though no other objective prognostic factor came out. And looking at with tumor thrombus, no thrombus, 20.5 months thrombus, 11 months in the entire cohort of patients. Much better for both groups of patients and only the last 2. So just as others have reported, and as we saw initially, the biggest, I think, potential complication is a decline in liver function using the Child-Pugh score. And this shows any change, even A5 to 6, and the red is change from A to B. So at 3 months, about 28% had a decline in their liver function, more than I appreciated, even though many of these patients had treated. This is looking at all patients who had no progression. So progression wasn't going to impact the change in liver function. And interestingly, in these patients, with time, their Child-Pugh score returned. So similar to some of the talks this morning, that some of the insult is transient. We're still investigating this, why this has happened, and my guess is that the portal vein thrombus has a delayed response to about 6 or 9 months, and perhaps when that opens up, recanalizes, then there's more flow to the liver and a little bit of improvement in function. And at the beginning, perhaps edema or tumor progression, delayed response can contribute. But we weren't expecting such a high rate of change in child score. Another role for radiation is bridge to transplant. We have an extremely expanded criteria plant transplant program, living donor and cadaver in Toronto. And so many of these patients have large tumors and sometimes not suitable for our favorite case. And so our first experience was in 10 patients. None of them had local progression, taking them off the list. A few developed metastases, taking them off the list. And at explant, we saw 50 to 100% necrosis. So one patient had a complete obliteration. But most of the time it's bridge to transplant. I'm not aiming to ablate, I'm aiming just to stabilize, to hopefully keep the patient on the list and not cause them harm. For small tumors we can ablate, but not for larger ones it can be risky. Most of these were child B and C patients. So what about sorafenib or targeted agents with radiotherapy? This is an example of a patient I treated with a portal vein thrombus who had AFP more than 10,000 in 2009. And 8 months later, after, in fact, relatively modest low-dose radiation with sorafenib, there was complete response of parenchymal tumor and thrombus and AFP down to 24. I think this is a little bit of biology, not just treatment, because clearly this doesn't happen for every patient. But it did provide us with a motivation to do phase 1 studies of sorafenib combined with radiation. And they've completed and will be published, or will be presented later this year. And in brief, as you'd expect, there can be increased toxicity, but perhaps increased efficacy. And so it's hard to combine sorafenib with radiation. There's one study of combining a different tyrosine kinase inhibitor, sunitinib, and this is retrospective from Taiwan. And these patients, relatively advanced disease is shown here, about a third child B, 15 fraction radiation, a good dose, a hot dose of radiation. And sunitinib was used prior to radiation, during, and in some patients following. The median survival was 16 months, better than I would expect, and median time to progression 10 months. And maintenance sunitinib was associated with increased survival, as shown here. Now it's retrospective, and not so surprising perhaps, because maybe patients who were still having good liver function were the only ones who continued on drug, or maybe they had better performance status. It's hard to say. They didn't report any grade 4 or 5 toxicity. There was one grade 5 thrombocytopenia, and I'm a little bit surprised about that, and I think we just have to recognize that's retrospective, but again, some motivation to study targeted agents with radiation. So based on this and our own experience, we've launched a randomized trial in hepatocellular carcinoma via the RTOG. I'm the PI of that study, and it will be with international collaboration. Taiwan and Korea and Hong Kong have already endorsed and will be on board. The study is sorafenib versus 5-fraction stereotactic body radiotherapy followed by sorafenib, 1-to-1 randomization for patients with BCLCC, disease unsuitable or refractory to TACE, child A only. And the primary endpoint is overall survival. 400 patients are planned to be accrued to the study. Stratification factors here. And this will be tricky. There's going to be much quality assurance. Every single patient who's treated will have their scans, images reviewed by at least an oncologist and a therapist who's going to review dosimetry. So it will be a difficult study to accrue to, but I think if radiation is ever going to be recognized by the Barcelona group, it won't until we do randomized studies. So I hope we can accrue. So in conclusion, radiation may indeed benefit hepatocellular carcinoma patients of all stages. There's no level 1 evidence today. Hopefully we'll have level 1 evidence, at least for advanced stage in the future. There's a dose response for local control, but there's also potential for increased toxicity as more liver volume is treated and in patients with impaired liver function. So this really provides the motivation for our high-precision radiation techniques more than many other sites, because every cc of liver we can save or spare from being treated can potentially help the patient down the road with more liver reserve. And I think, as I said, I'm hoping our randomized trial will actually activate, and many people contribute to this slide. So thank you again.
Thank you, Dr. Dawson, for your fine and nice speech. It demonstrates that the radiation therapy role is evolving and is increasing. But I think that the limit of the technique means that is increasing because it's associated with other techniques.
Yeah.
Do you think that it is by itself?
Right. Well, my own experience is refractory to all the other techniques. I do think if we combine radiation with other therapies, we're going to make much bigger progress, because it's a local therapy in an advanced setting. Many of the other experiences from Asia have combined with regional therapies. It's true, where perhaps there's a little bit of a gain. Hopefully, if we can show a survival gain from radiation alone, simple radiation in advanced cancer, then the next questions could be, how do we combine it with standard therapies, whatever agent is available in 3 to 5 years? I don't think it'll be, it might be sorafenib, it might be something different, because then we definitely can look at that, fine-tuning how radiation is delivered.
First, congratulations, and I think that this is really, you know, we learned that there is a long story, but nowadays I guess you have the technology to be really authoritative. My concern is related to the last study that you are running, is, and in this sense, we may point out, because when you speak about the guidelines of the Barcelona clinic, and then endorsed by American and European associations for the study of disease. There is one point, therapeutic option is only suggested. It's not a rule, but it allows to design study like this one, in which I may say that main portal vein, it's okay, but you included patients with vascular invasion of branch of the portal veins.
Yeah. It's variable in the world about regional.
And it means that if you administer sorafenib to them, most of them should be also child A.
Mm-hmm.
Then, because on the BCSCC there is no mentioning of the surgical outcome, you may study, you know, it's ethically acceptable, a study in which a priori is excluding to the option which is, at least according to the, you know, strong literature in this sense, that could be cured in a better way. I think this is a concept, I'm not against it. I think that this study should be done, but at least there should be a point included that there should be the selection for surgery. And unless it is not included in this BCSC, I feel that it's not built for SBLT, but is too much oriented to sorafenib.
Right, I agree with you 100%. And I haven't included all of the eligibility criteria. These patients have to be assessed by a surgeon, and multidisciplinary setting clearly cannot be suitable for surgery or radical approaches, even transplant, to be eligible. When I first pitched this trial, this has actually been 5 years I've been trying to get this trial going, I approached it as only main branch portal vein thrombus. And my mostly American colleagues wanted to expand it. And the reason is probably a little bit of center-to-center variability in expertise, and that some patients refractory to TACE may still not have portal vein thrombus or may have little small branch. So it's interesting, that's why we stratified for it clearly, because you're right, these are very different patients than the main branch portal vein thrombus. So I'm not so sure how many branch we will have, and the accruals an issue too. So it's very hard. The study's compromised as you want to have more people participate. So I wrote here TACE, but clearly, the eligibility have everything else, RFA, transplant, and regional therapies as well. And you had another question, maybe?
No.
Okay, thank you.
Just a curiosity, and I don't know if what I am asking to you is obvious of stupid, because I'm so far from your method of study, and I want to know, is possible the brachytherapy of HCC by the insertion of percutaneous insertion of radiotherapeutic seeds in the mass?
Yeah, that's a great question. There's far less published for brachytherapy, and there's different ways to do that: percutaneous high dose rate or insertion of low dose rate iodine bead. There's a relatively large, impressive experience from Germany, and they're the most experienced group with percutaneous radiation for HCC. And they've reported that they do treat patients with main branch vascular thrombus, even with the brachytherapy. They've just now moved to MR guidance, which will, I think, help them a lot. And their results are impressive. Actually, I don't know if they're published yet, but I've seen some of that data unpublished. So in the right hands, with the right team, clearly that's a multidisciplinary team, it's possible. It's technically challenging, and not everybody has brachytherapy skills or the collaboration with interventionalists to do it appropriately. In Toronto, we have another center, Odette, and they have a small pilot project using inserted radioactive iodine. So they're thinking about it, but now only doing in very small cancers, which I'd love to treat small cancers, but there's so many other therapies we've just heard about. I don't think that's where radiation should play the main role. I think it's really, at first, those who are not suitable for standard of care treatment options. But there's a role. So probably need more experience for the toxicities and more published, especially the German group. I'm sure we'll hear about that more in the future.
Very